Well, good morning, everyone. I'd like to open this Polk County Board of Commissioners session. It is December 6th, 2022. All commissioners are present. Please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America, to the republic for which it stands, one nation, under God, indivisible, with liberty and justice. Thank you, Lynn, for comments not on this agenda. Hearing none, looking for approval of minutes from November 29th. I'll second. All those in favor, please say aye. Aye. And that brings the Health Services Department update. Dr. Noel Carroll. Good morning.
Morning.
I did forward over a packet for you to follow along. Mostly it's pictographic, so there's not a lot of narrative. So for anybody who doesn't have it, you should also be able to follow along just by listening and asking questions at the end. Wanted to start, Commissioner Morthorst, you asked a moment ago about how we were doing with recruitment and workforce issues. So I was actually going to start there with just an overview, just to bring everybody kind of up to some context. The overall workforce for health services as a department is a total of 181 folks who contribute to that total workforce. That includes our regular employees, contractors, and interns. The vast majority of those being regular employees, with only about 9% contracted positions, which are sometimes partial positions, sometimes just a couple of hours a month even, for some of our specialty positions like occupational therapy that we might share with other counties, all the way up to the equivalent of a full-time position. And then interns account for about 4% of our workforce. Those are mostly all within behavioral health. The average years of service for our employees right now is almost 5.5 years of service. So for those who have been with us, the tenure is actually pretty healthy. We currently have 17 vacancies. That does not account for the funded positions that we have received over the past 8-10 months, funded by the state for a lot of new programming. Those are just vacancies that we have had and been trying to fill. The total vacancies, I can't give you a precise count because we're still negotiating some of those funded positions, but it's probably in the neighborhood of about 25, 28 total vacancies, with the vast majority of those being within behavioral health. Of the positions that we have filled since July, 43% of those have been internal fills. So while that's great because we're seeing some growth within the department and allowing people to move up, we're not seeing a lot of new blood coming into the department. So it's really shuffling where the vacancies are present rather than resolving those vacancies. Some of the hard to fill positions, just to give you a sense of what we've been facing with that, are happening with our professional level positions, our master's level mental health counselors in particular. Since July, we've been dealing with 10 vacancies. Over that time, we have had 2 qualified applicants apply. We have currently 5 vacancies that still exist. The reason that math doesn't add up is that we did go to the state and apply for some variances so that we could actually hire 5 interns that were interested in fulfilling their schooling obligations offline and working for us full-time while they finished that. We talked a few days ago about how the state has been modifying the expectations around what qualifies for somebody to provide services and allow us to bill. So this is an example of one of the variances that they've recently put into play to allow us to kind of stay afloat as the system is trying to work out some of the workforce issues. To kind of give you a sense of what the impact of that is for my outpatient department, we typically need about 30 bodies doing the good work there. 7 of those look like the typical qualified mental health professionals that we would have seen 3 or 4 years ago. The other positions are either contracted or part-time or interns or just of a different type of position than we would typically have seen in the past.
So you're saying we have 7 UMHPs, master's level on staff current?
We have more than that. There's a lot of nuance to how how it all looks and how it all comes together. But only 7 of the positions are the traditional level of professional that we typically would have seen. And public health, we have continued to have and have for over a year, 3 nursing positions that we've been trying to fill. We've received 0 applications for those, and we continue to have those vacancies. We recently have been trying to recruit for a nursing supervisor within public health due to an upcoming retirement, trying to get ahead of that one. We did receive 1 application for that, went through the recruitment process. Unfortunately, they declined once we got down to it. And so that vacancy is something we're continuing to recruit for. And then our after hours crisis is another significant area that we're working on. We have ongoing recruitments for those and have had a very difficult time getting anybody to apply for those positions as well. So those are kind of the highlights. There are many more vacancies than those, but those are the ones that kind of weigh on us the most, have the most significant impacts to our day-to-day functioning. So moving towards more department-specific updates. Public health. They have 4 current vacancies. We talked about some of those a minute ago. The impacts there to their clinical services, most importantly, they have a series of home visiting services that have been closed since May of 2021. And that's due to the fact that they require RNs to run those programs that we have not been able to recruit for. So right now we do receive referrals for some of these programs. We have some case manager level staff that are able to kind of triage those referrals and make some connections for families and recommendations for other programs. But the medical portions of those, we're having to either try to connect to other counties or other facilities, but we're not able to provide those services currently. So those are closed. On the communicable disease and immunization reproductive health side, we have 1 RN who runs all of that. She is expected to be out on military leave March through May, which will bring those programs potentially to a close if we don't have a nursing supervisor who can potentially backfill to cover for a portion of that. So our hope is that we will have somebody in place that can do that. Otherwise, the only other medical staff we have is 1 nurse practitioner who currently does reproductive health 1 day per week. So our clinical programs within public health are kind of in a dire position at this point. They are having some other successes though in other areas, and some really exciting things are continuing to happen. So it's not all bad news. Our WIC programs continue to be very healthy and are being quite successful. We have 900, a little over 900 families being served there. We have a 90% show rate. So the good news is that families who need help seem to be connecting to us. We're reaching them. We're continuing to see them routinely. And our staff are doing well there. The staff in that program have been with us for over a decade and are continuing to serve that population and are very skilled in that. Immunizations continues to be something that is happening really in a robust way right now, particularly with flu vaccines. Our flu vaccination clinics, we've run 4 since October, and our flu vaccination rates in Polk County are higher currently than they have been since pre-COVID. That's just up to date. So that's really taken off, and we're happy to see those numbers climbing. I already mentioned the upcoming retirement of our nursing supervisor. We're working on that, but Cindy Rettler should be recognized for her longstanding work with us. She's worked both in behavioral health and with public health for many, many years now. And then our public health administrator, who has been with us for less than a year, is just taking off in leadership roles, which I think is a great way for her to start to help build back up the public health programming and start to make some connections that can help us to rebuild that. She's currently taken on the chair of CLO. She has also stepped up at the Willamette Health Council and taken on my spot. My time was done as co-chair of the clinical advisory panel, so she has stepped in my stead, and I continue on the committee, but she gets to do all the fun planning. And she is also doing a great job of developing our preparedness work within health services and working really closely with our EOC and developing that relationship, which is something I'm really happy to see happening within the county. I think that's an important relationship build. So good things happening there as well.
Acronym warning.
Thank you.
You said CLO.
Hello. Hello. All right, here's a test. It is the Coalition of Local Health Organizations. So it's the public health affiliation body underneath AOC. I think they're affiliated members. That
Yeah.
how you would put it?
As the
Okay.
Association of Oregon Counties. I do that for the benefit of.
Thank you for the record and anybody listening who's not an acronym junkie.
right.
List, thank you.
I'll scratch that question off my list. Yep.
Yes.
Before you move
Yes.
from the public health page.
Yeah.
Let's talk about, this is a frustration that we've had for my 12 years here. Again, I understand the need for counties to have a public health presence, and specifically in the communicable disease realm for sure. But all of these things we've been striving to get into the hands of primary care forever. Where do you think that we stand now with coordinated care organizations and the efforts to get primary care to pick up 100% of the responsibilities and the education? I know we'll never meet 100. I get that, but that's the effort, right? Is to try and get, community health to be managed through people's primary care physicians and their primary care homes. Are we making any progress there, or are we always going to have a population that just isn't ever going to get their needs met there? Because that's the reason why we do these things.
Exactly, right?
So,
Public health is still, I think, intended to be kind of a safety net
Yeah.
for that population. And my guess is we're always going to see some segment of the population that needs that safety net. I'm hopeful that we will see it decrease. I think we're seeing, if nothing else, conversations that are moving in that direction. Recently, through the Willamette Health Council, there have been some really good conversations, particularly pertaining to immunization. And we've seen that in Polk County over the last few years, where there's a lot of red tape, and there's a lot of hoops to jump through when it comes to obtaining vaccine, storing vaccine, billing for it, tracking it. There's just a lot involved. And whether you can get it from these sources that are wanting to make sure that it's readily available to anyone. So we are seeing primary care ask about it. We're seeing the Willamette Health Council take an active role in asking what's involved in it and how they can support that being something that has a lower barrier to primary care. So we are seeing some of that taking place. It's one of the reasons I'm excited to see Naomi in particular having a lead role in the clinical advisory panel. I think public health historically has had a smaller voice at those tables. And I think making sure that the larger group understands the role that public health has historically played and where that crossover exists is part of what's necessary to move that forward. So for example, we're still educating the players there, and the players being a lot of local primary care, a lot of the insurance and payers that are involved, the hospitals are involved, with understanding that we provide immunizations and that some primary care doesn't. In fact, we'll have, and I think that was something that was missing on a lot of folks not understanding that that's something that happens locally, where we'll have people who go to their primary care doctor, and that primary care doctor will say, well, we don't do those immunizations, go to public health for those. And that's actually a cost that we're incurring that we're not reimbursed for fully. And so then when we're talking about global healthcare savings and how those should be distributed, making sure that we're being recognized as a part of that pie and a part of that contribution. And that's a first step. The second step would be, that's great. We want to be recognized for that contribution, but how about we find a way to actually shift that so that you don't need to send us that. And instead we get this work being done at the point of contact where you had that person in your clinic in the first place.
Immunizations are not covered by primary care generally.
Couldn't tell you off the top of my head.
It's interesting.
But I'd be happy to have Naomi come back in and talk about that. It's something that, like I said, Willamette Health Council is very interested in right now about trying to dig into this and understand it better so they can support shifting that.
I guarantee the percentage of people that actually seek out public health for those is very low.
Yeah.
I would imagine.
the frustration with that particular subject is I have 10 years of experience in that very thing, and it hasn't changed in that 10 years of the conversation with coordinated care organizations and with primary care. So the issue becomes eventually for us is the business model here. And the fact is we're competing with those very organizations, the private healthcare industry, for our staff. And we can't compete typically. And so at some point, counties need to push a little harder here, I think, in these conversations with the associations and with the CCO about, look, this isn't practical. We can do the oversight part and some of the education piece, but when it takes these certified staffers to deliver these services in competition with the industry, this doesn't make sense to me. And we've got to find a different way to do our job as the public health administration and overseeing it, but not necessarily delivering the final product. It doesn't make sense for us to be doing this. So that's my 2 cents worth in that. Going to continue to lend a voice towards that, that we need to crowd the industry a little bit harder on making sure that they deliver all that they can, so that people aren't dependent on on a government institution that's competing to get that done. So any ideas in that regard, I would love to hear them going forward in more conversations, rather than acquiescing to, well, I guess we just have to do it. It just doesn't fit. Thanks.
Yes. Okay. So segueing to behavioral health in the larger department sense, then we'll come down a little bit. I wanted to just briefly talk about the funding model that supports behavioral health, and then give you a couple of brief bullet points on some of the potential funding impacts that are coming so that you can be hearing for those as the legislative session heats up. Basically, behavioral health has 3 different pillars of funding. There's variable funding, which is variable because it's based upon how many folks are enrolled in Medicaid for our CCO each month. So for everybody who's on OHP that is within the Marion Polk CCO, we get a couple pennies for each part of a service that we're doing. So that's going to rise and fall with membership. So the good news on that one is that we have been above what was projected, as has the CCO, for the last couple of years. Right now, we're at a little over 136,000 members. The reason that that's important is that makes up about 23% of our budget ongoing. So we've been worried that at the end of the public health emergency, the folks that have been on Medicaid are going to have to basically reapply to make sure that they still qualify to stay on OHP. And we've been concerned that there's going to be a portion of folks who fall off that no longer qualify. Maybe they've gotten other jobs, maybe their circumstances have changed, and all of a sudden we see that number shrink of who's actually on the plan. That's going to shrink our revenue. So some changes have come through the Medicaid waiver 1115I. That should help to stabilize that somewhat. So 2 of these changes are that children under 6, regardless of after we're out of the public health emergency, children under 6 will continuously stay enrolled. They will not have to be reapplying. So until you're 6, you're good to go. Once you're on, you're on. Individuals over 6 years old, instead of having to reapply annually, which is what the process has been, they will have 2 years before they have to reapply. That will just allow the whole system to stabilize a little bit more and have a little bit less fluctuation happening within numbers. It's also going to buy us a little bit of time to assist families to make sure that they understand what's happening as we kind of leave this frozen period of time where everybody's been locked in, and help go through this redetermination a little bit more slowly. So I wanted you to know kind of what portion of our funding was impacted by any of this movement. And then to also say that I think it actually looks a little bit better than we originally thought. But we actually don't anticipate seeing a lot of impacts until 2024 from this anyway. Most likely we'll see redetermination begin probably early summer is probably the best guess we have right now, but we'll have to wait and see.
So Noel, how big is this region cover of the 136,000?
So that's Marion and Polk.
Marion and Polk County.
So the second piece of our funding is fee for service. So that's the part of our destiny that for all intents and purposes, we control. When we do a billable service, we submit a ticket, we get paid. So that's where we're able to kind of hire staff at the rate that we're able to provide those services, and we should be able to get enough money coming back in to pay for having those staff hired. So that accounts for over half of our budget. So we're able to kind of control our lever for more than half of our services that way. So when we go to hire folks, we usually know, depending on the area they're in, if that's part of how that part of our services is paid for, we can feel comfortable hiring staff because we know that if, as long as they're doing their job correctly, they're going to be paying for themselves. That's over half. And then we have the base rate contracted services. And those are things that mostly come from it's called the CFAA, which is our big state contract. And the state gives us money and says, you will do these things as the CMHC, and we will give you this much money to do it, period. So that's a flat rate, and that we negotiate every 2 years. And there's amendments that come in that you see routinely throughout those 2 years that changes those things slightly. And that accounts for about 22% of our budget. And the reason I'm bringing that up is because you all know that recently we agreed to a 6-month extension of our current contract that we will be negotiating, that will be coming into play then again in June. And the reason that we really wanted to extend that is they were looking to make significant changes within that contract, where they were asking us to do things that did not have funding that would have allowed us to provide the level of service they were requiring. So we're going to be trying to renegotiate that over the next 6 months, hoping to get something that looks more sustainable and manageable for us. And that would have only impacted about 22% of our budget, but still that's 22% of our budget.
So to be clear, the last communication we had through LGAC was that was a consideration. So was there something official that actually came down that said we're going to extend the contract?
We have been notified that there has been an extension accepted. We haven't received a formal letter, but we have had a couple of meetings with the planning team from OHA to walk through the extension process.
This increase, 30% increase,
Yes.
relevant to the CCO, was this expected? Is this in your mind a good increase in fee for service vis-a-vis the CCOs?
Sorry, yes, no, the last two bullets, the state increased the fee for service scheduled to reflect a 30% increase, and the CCO indicated a 30% increase across all lines of contracted services. Those were both expected.
Okay.
Those were both the increases that the state was putting out to support the increased wages that went through with House Bill 4004. So we were anticipating that. We were in good faith trying to use that to stabilize our workforce. And that's just the confirmation that that is coming.
For a fixed period of time?
Well, until it were to change again. But at this point, there's no end date on that. That's just the new rates.
Your historical knowledge, have they ever backtracked on that percentage? Reduced it?
There have been cuts to rates,
Okay.
certainly. And they do it in various ways. They'll either reduce the rate or they'll change the level of what qualifies to be included.
Find creative ways.
After you've loaded your operations with more employees.
Sure.
So then getting into the two major program areas, just briefly, developmental disabilities, then we'll talk about behavioral health programming briefly. So developmental disabilities is actually probably the healthiest of all of our programs right now in terms of stability. They are nearly fully staffed. In fact, they've hired 2 new staff, added 2 additional FTE that were funded by the state for some additional areas of focus. The state really wanted to see outreach to underserved populations happening. They really found that there was an inequity that appeared to be occurring with who actually applied for assistance through developmental disabilities and wanted to reach some underserved populations. So we have 2 new positions that are funded. One is focused on training and recruitment of DD foster providers, and the other one is solely focused on service awareness and marketing outreach to underserved populations. So we're really focusing on BIPOC, tribal connections, and making sure that people understand how to access the services, what those services can provide to families. and how to walk through the processes to obtain those. So we have those in place. Their contacts with their clients are popping right along. The staff are working very hard and their claims are exceeding all of their billable requirements right now. So they're doing very well. That's important for us for a reason that I would hoping to get your support on as we move into the legislative session, which is listening for things related to the workload model. The workload model is basically what a study that has been going on to look at what's the expectation that the state has put on the service providers that do the work for developmental disabilities and if it's being funded appropriately. This has happened for the last 2 sessions. And the first session, I believe they came back and said, nope, it's not being funded correctly. We will fund it up to 75% of what we think you need. And the next time it came up to about 85% of what we think you need. And we're continuing to say, hey, if you think this is underfunded, could you please completely fund it? So that continues to be the push. There is a report due to the legislature this month in advance of the session to outline how the current case management system could be paid for. And a model put forth that CMS would hopefully support. So we're looking for that. And then that is supposedly going to also be used to take a look at the different classification of positions that are used by DHS to then support the positions that we hire to see if those positions appear to be being funded appropriately with the intention that we're recruiting and maintaining staff that are trained appropriately and going to be able to stay here rather than having somebody else hire them away because we're able to be funding them at an appropriate level if they want to stay with us. That's happening with DD. They're in a good position right now.
We ever have to separate DD from behavioral health in your mind, just for funding purposes?
It would
Because
be,
they have their,
it would be
essentially their
cleaner.
own silo of money, and the rest of you live on more of
Yeah.
the other page.
It would honestly, from the way that I work, it would be easier if DD looked more like public health.
Right.
Where we're still all under health services, but there we weren't quite so confused within behavioral health.
We'll work on that.
Okay. And then behavioral health programming, some brief updates to let you know kind of what we're looking at as far as volume of people seeking services. The graph at the top, there's a dark line across it at 170. 170 represents the average number of people seeking services each month prior to COVID. So it kind of gave you a baseline of what life was like prior to COVID. Over this year, we have popped all over the place, far above, and for the most part, trending right about at that average. We are not staffed in a place to be able to support that average. So we have been struggling, but we have been maintaining our open access. People are able to still get services on the day that they call and say, I want to come in. It has just meant that we are scrambling routinely and calling all hands on deck all the way up through our management and anybody else who's qualified to provide that and get folks seen and make sure that they're connected with the level of service that they need. So we're able to do that today. One of the things that I wanted to bring before you, though, was just kind of a heads up that I don't know how long we can maintain that. One, because it's putting quite the load on the rest of the workforce that's trying to do other jobs. And 2, and probably more importantly, just because we can get somebody in and seen, I have growing concerns about our ability to also be providing good care after that point in time, because just because you get them in the front door, there's got to be a period of follow-up. And at some point, you kind of create this bottleneck. And I don't want to be bringing people into services that we can't ethically and effectively serve beyond that point. So there may be some short periods of time where we have to kind of stabilize and allow some things to clear out where we're going to have to close our front door. I would hope that those would be very short-lived. And we don't want to have to do it at all. We're working on some other creative programming that could help us to avoid that. But I wanted to make you aware that if I got to that point, that would be something that I would want to do in lieu of providing services that I didn't feel comfortable providing. And that could potentially also be the case with medication management. We have had to do that in the past for, again, brief periods of time where we've gone for a couple of weeks with closing the front door to allow to create some room within the system. At this point, we haven't done it, but I wanted to make you aware that that could happen, especially because I think when that does occur, you tend to hear feedback from the community about having concerns around that. The other things that are happening within behavioral health is we are looking towards the retirement of one of our senior managers. Carrie Blum has been with us for about 13 years. She has been in charge of everything having to do with youth and family for that period of time. And she will be retiring. We're in the process of looking how we're going to restructure our management structure essentially, and how we're going to do things differently. The way that I've been talking about it to folks is that gone are the days of us swinging for the fences. It's time to play small ball. We got to get people on base and we got to move them around. So that's kind of where we're heading, is we're trying to rethink how we've been doing things and trying to create more specialization within what we do, trying to create more opportunities for staff to pick up pieces and make those pieces manageable, rather than expecting that we're going to find a lot of unicorns, which are easier to do in times where you have a lot of applicants coming in and a lot of healthy submissions. It's not easy to do during the time we have, so we're changing our strategy a little bit and trying to make sure that we're pairing up skills with our needs with the folks that we have. So we're going to be working through some of those issues over the next year. She's not planning to leave until fall, but with a position like hers that we need to cover, that is not a lot of time. So we're working through that. We've already discussed the state contract extension. That was just something else I want to make sure you knew about. And then the program development that is going to be taking up most of our time is going to be around 24/7 crisis response and rolling in the youth crisis response, which we haven't had as a formalized program historically. And that's going to be coming on board over the next year as well.
Did you have anyone in line in staff to, I mean, you have 2 supervisors retiring within the next year. Anybody in-house that can take their places?
Not to that experience and caliber. So our best strategy right now is, like I said, to kind of redistribute tasks, to break them down into smaller pieces and to try to train people up that we currently have. We really are, when we look at where we're heading, particularly in behavioral health and health services administration, within the next 10 years, we will likely lose every senior position we have, with the exception of me, as long as you're willing to keep me. And that's a very frightening outlook from my chair, because I don't know how we deal with that and the workforce issues that we have to try to recruit those backfills.
How heavy are the workloads per individual case manager?
For managers or for?
Well, for your counselors, how many patients are they seeing per counselor? What's the workload?
The patients that we're seeing per counselor should be in the neighborhood of probably 50, and right now they're between 75 and 85. So we're down probably about 1/3 of the folks that we should have as far as counselors. And the managers and the supervisor staff are all carrying multiple hats. And again, I think it's my best strategy is to change strategies about how we've been structured and how we've done management tasks in the past. I think it's a matter of changing the play. And frankly, that's what I've got to work with, because I can't create new people. So I think we have some good ideas. I think we're making some creative plans right now, but it's going to be a time of change and a time of hopefully creativity, and maybe there'll be some Phoenix moments out of that.
Any other questions?
Really appreciate your leadership through all this change.
Well, thank
Major
you.
disruption
Likewise.
in your work, one, COVID obviously, and then also this effort to expand services at a very accelerated rate. Man, we have cash, but we need to build the organization. We need to build the structure. That doesn't happen overnight. So thank you for being creative.
thank you for the latitude to try the things that we need to try. Thank you.
Thank you. None less today. Hearing none, meeting adjourned.